Question is, you had touched on expectations and results, and that got me thinking. You're dealing with human beings, and human beings are, whether you believe in the Bible or not, or whatever one believes in, but man is fallible. And so man makes mistakes. Everything on paper looks good on paper. These are my personal beliefs. Every theory looks good on paper. Every ismocracy, all these theories are great on paper. But once you need man to enact them and do them and see them out, that's when you start to run into problems. We have 7 deadly sins for a reason. So I always believe man is fallible, and that's where things go off the track, unfortunately. Right. That being said, you're dealing with people, and talk about... What is he hearing? Talk about expectations and results. What are the expectations from the facility itself, what it expects from the counselors? I'd like you to touch on that. And then I want you to touch on what are the expectations from the patients of what you are supposed to do for them, what they're supposed to get out of this, what's a success. So if you can cover it from both ends. Sure. And then I got to follow up with a whole separate question of that. But tell us what expectations and results.
So you talked about being fallible, and it's a good subject because nobody's perfect, and the imperfection is what makes this great, what makes this industry great, because you can assist in healing people that already have cracks, and you can help them fill in those cracks. They're imperfect. The person that helped them is imperfect, but they're unique, and they're their own person. There's nobody else like them. So if you start from that point of view, the theories that are used within the industry, they all have their good points and their bad points. There's some that are extremely useful for certain types of patients, and there's some that are not so useful for certain types of patients. And so, the facility has the responsibility of identifying the best research-based techniques and theories that generally work for whatever population that you're working with. Whatever it is, mental health, addiction, eating disorder, so on and so forth. So the facility has that responsibility. The counselor, the therapist, has the responsibility of doing no harm. That for one day and one day at a time, they did their job. So let's say their job entailed running groups, doing individual therapy, writing their notes, calling a family member, and consulting with their supervisor or a coworker. And let's say they checked off all those boxes. Did they do that? Yes. Well, that was a good day, and that would be my expectation. Let's say the next day, all those things weren't done because there was some patient that was chaotic and had all kinds of problems, and you were distracted. You were taken away. Well, within that context, did you do your job? Did you, by you being involved in whatever episode there was, were things done the correct way? Were things done and you were helpful? If the answer is yes, then you go home and you feel good about yourself. Now, there's a lot of clinicians out there that don't feel that way. They constantly feel like they're a fraud. They constantly feel like they didn't do enough. They feel that way, and that's where the facility and a clinical director and a manager and a supervisor, they come into play, and they temper expectations. There's a certain box that that you can work within, that you can expect from a clinician and from a therapist at a certain level of care. And I think many times therapists have unrealistic expectations of a patient. That they're going to actually, their anxiety is going to be significantly reduced over a 30-day period of time, or that they're going to be compliant with their medication, or they're going to bathe every day. I really think that we have to start with very small expectations, again, depending on the population and the treatment history and all that. But you have to start very small, almost to the point where you want to set it up where you're pretty sure that therapist and client are going to meet these expectations at least out of the gate. So that's very important for leadership. And as far as patients go, they have to know what's expected of them. They have to know what the therapists are going to do with them. They have to know the rules. And their job is to break the rules. Their job is to not behave. Their job is to not cooperate. Why? Because they're sick trying to get well. And they have a whole history and a whole past of not being well. So you have to model those expectations. You have to reinforce it. The key to all of this is structure and consistency and small attainable goals. That's the key to the whole thing on both sides.
What would be in your eyes, what's the recommended stay to truly make a difference? Because you're right, 30 days to change very serious problems that people have been dealing with for years seems like a stretch. Certainly tough. Two-part question. What do you recommend an average stay would be? And do you think there's a segment of people that they need this forever? They're never going to get on path once they're left to fly on their own. Their only chance, kind of like elderly that get put in a home, maybe do we need more of where this becomes a path for people? They're always going to need a counselor. They're always going to need somebody to make sure they bathe, to make sure they take these meds or whatever.
Right.
Family can't always be counted on that. So there's a segment of people, I imagine, that need this forever, so to speak.
So the length of stay it varies, but in truth, 90 days through 18 months to 24 months for a chronic drug-addicted individual or someone who's chronically mentally ill, who has gone through the ringer, is the length of time that could help a majority of this population. Yes, there are patients out there that have met their baseline, meaning this is their level of functioning. This is it. They might have some few days here and there, a few months here and there, but basically this is it. They can take their meds, make their bed, eat their food, socialize, participate in group to a limited degree, but not capable of working, maybe volunteer a little bit, interact with their families in a structured manner, and that's that could be that could be their baseline. There are patients that are like that out there. Unfortunately, we don't have a system that can take care of those kinds of patients on a wholesale global setting. That's why we have homeless people. That's why we have prisons are overcrowded. That's why we have treatment centers that take people that they shouldn't take. It's definitely a systemic issue, but that's the gist of it.
Pretty interesting, because you see people that get put in homes, mentally ill, so to speak. But I feel that that's a little different than somebody who just needs that sort of walking through all the time. So it is that is an interesting point. So my follow-up to that would be, and that is, what do you see more of, and why do you think you see more of it in terms of mental health versus drug abuse? What's the breakdown? Is it 50-50, or does it lean heavily one way? and you mentioned the duality situation, so maybe it's both, but I'm just curious, what do you see more of in your walk, and what would be your hypothesis for why there is more of one than the other in that industry?
So again, this is an important subject because there's always been a debate between, what came first, your mental illness or your drug addiction. So I want to set the record straight here. It's both. It's under the umbrella of behavioral health. Drug addiction is a mental illness, and it should go under mental health. Drug addiction has its roots in trauma and obsessive compulsive disorder and an anxiety disorder, and so it's really all under this one big umbrella of mental health. It all depends on how to treat them and their level of functioning. There's different ways to treat people because, well, they behave differently, and some are a little bit more they're higher functioning than other people. Schizophrenics that are psychotic, they have to be treated with med management more than a drug addict who just came off of cocaine. So it's all under one umbrella. I will tell you this, that in treatment in general, in drug treatment, if you will, right now we're seeing an epidemic of young folks about 20 to 25 years old, really hooked on opiates, and that seems to be extremely prevalent. You also, in the mental health side of it, you see a lot of depression and a lot of anxiety, a lot of suicidal ideations, a lot of suicide, and again, you see that in a lot of younger people. COVID has somewhat skewed things because of the isolation, but it's still relevant today.